Hi, everybody. Welcome to episode number 156. This is Susan Clinton, one of your co-hosts of the podcast Tough to Treat. And this is part two of the short webinar that we did 2 weeks ago on the interactions of the functional anatomy and physiology of the GI system. This particular aspect of the webinar will give all of you a nice story of these systems and how they work in digestion and how this affects the other systems of the body. Have a listen and let us know your thoughts. Enjoy the podcast. So as we consider the neurology of the lower GI system, we also want to consider the vasculature of the GI tract as well. The circulatory system is fed by the mesenteric artery with many branches, and you can see in this picture all of the redundancy of the circulation and the richness of the circulation in this system. It's all fed through the mesenteric pathways and along the mesenteric folds, which helps house the nerves as well as the arteries as we go through. The top left-hand corner is one area where the blood supply is not quite as redundant, and that's generally the area that will get in trouble with ulcerative colitis and or any kind of necrotizing colon thing that goes on. One of the things to keep in mind is, remember, we just talked about how anything that gets into the blood supply that doesn't belong there is going to be problematic, and you can see the richness of the blood supply here. So it's important for the good digestion to occur and the intestinal mucosa to be nice and strong and not have weakness in its cell walls to allow amino acids and other things to get into the circulatory system. I love this slide because in this particular slide, we get to have a chance of thinking about the system from top to bottom instead of just regionally. As physical therapists, we tend to just look at the pelvis or maybe the abdominal and pelvic area. But with this course, I want you to be able to see up and outside of that and consider other factors and influences on the GI system besides just the muscles of the pelvic floor. So this is a great picture because it shows food coming in. One of the things it doesn't show is the eye that the other pictures earlier showed, because we need to see our food, eat our food, want to eat our food. And when we see things that we want or we're excited about, we get salivary digestive juices starting to flow. That's important because it helps us with the digestion piece of what we're going to be doing in our mouth, which is chewing. And chewing is one of the things that will get the digestive enzymes going and floating down the esophagus to the stomach. This is super important because it's the digestive enzymes that tell the stomach it's time to start churning the acid. If the stomach doesn't have good quality acid or good churning going, the cardiac sphincter, which is the sphincter between the esophagus and the stomach, doesn't close well. So that actually leads to more problems with reflux than having really great stomach acid and having that sphincter close off. It's an important part of digestion. As the food enters the stomach, it is very acidic, and there's a lot of breakdown of the food that goes on here. So it has to be broken down very, very, very well so that as it enters into the small intestine, the different enzymes in the small intestine can begin to break that food down further and get it absorbed through the villi. So a lot of chemical digestion is occurring here. Acid from the stomach, then it moves into the small intestine. It becomes more alkaline with the help of bile from the gallbladder that comes through. All that chemical ingestion and digestion continues until it moves into the large intestine. And in the large intestine, that's where we're going to get a lot of water added to the stuff so that it can be turned around and everything can take place. And then the water will be pulled away so that the feces can form and slide down into the sigmoid, into the rectum, and out through the anal canal. So some of the functions that we want to consider with the digestive system that we don't always think about, but we want to think about the mouth. And again, physical digestion is occurring by the teeth. We have teeth that were meant to bite, tear, and pulverize our food. It's very, very, very important that we do that because, again, the digestive enzymes are stimulated that way. When food enters the mouth and the salivary glands are going, we produce saliva, and that actually helps soften the food and make it much, much easier to swallow. The chemical digestion is done by the digestive enzymes that's coming into the system as well. The digestive enzymes in the food are moved down the esophagus by peristalsis, and the stomach accepts them and is producing hydrochloric acid and protease, pepsin enzymes, to further digest the food and pulverize it down further to the kind of material and chemistry that the small intestine can handle. So we don't want large chunks of food coming out of the stomach and getting into the small intestine. And in fact, that's the reason people may have small intestine bacteria overgrowth. It's because they've got food rotting in their small intestine. It's not cool. So chew your food so you can get your stomach acid going. Make sure the stomach acid is going well so it can finish digesting the food and the small intestine can begin to handle it. The big function of the large intestine is to put water in and then take water out and really absorb the water out of the stool so that it can become feces that can be sent down the waste canal. And then the pancreas is there to provide some other enzymes to help deal with sugars and carbohydrates. So some of the digestive enzymes that are so important start in the mouth and are broken down by the teeth and the glands that are producing these digestive enzymes. As they pass out of the gut, or as they pass out into the gut, and they help with the breakdown of food molecules a little bit more into the small intestine, where we get amylase, which breaks down starch to sugars, and protease, which breaks down proteins to amino acids, and lipase, which breaks down lipids to fatty acids and glycerol. Remembering that what the body can absorb into the bloodstream and what can be used are these very, 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 very small things, not big proteins and not big fatty acids and not big starches. That's going to cause an autoimmune reaction in the bloodstream if the big things get through. We only want the little things passing through where they're supposed to go. We want to consider what bile is. We want to think that it's not so vile. After the stomach, food travels into the small intestine. The enzyme in the small intestines work best in alkaline conditions. But remember, the food is really acidic as it's coming out of the stomach. So bile is really important because it's very alkaline. The gallbladder will produce bile and push it into the small intestine based on the chemistry that's coming out of the stomach. So the bile is secreted into the small intestine where it emulsifies fats, but it also plays a role with breaking down further carbohydrates as well, because you have some bile in there and you get the alkaline or the alkalinity up in the small intestine, then the enzymes that really break the carbohydrates down to much more smaller and usable molecules can work better. So some people who can't deal with fibers because they just make them too gassy and too bloated and they're too hard on their system need to probably cook them, grill them, do something a little bit different with them so they're already partially broken down by the time they start to eat them. So some people, raw vegetables and things like that, don't do well with them because they just can't break them down enough. And generally you find that in people following gallbladder surgery. So when we talk about the small intestine, we want to think about the village of villi. So this slide calls it silly villi, but I kind of think of it as a village that's all along everywhere. It's just a big city all spread out over the length of the small intestine. And so the small intestine has a thin wall. And that's to allow great diffusion of molecules into the blood, the good stuff, the stuff the blood can handle, the stuff the blood wants. It has a rich blood supply for that. And remember, the small intestine itself is about 7 meters long, which increases the surface area. And then the villi and the microvilli on the villi increase the surface area of the small intestine by 1,000 times. So it's a pretty powerful absorption engine. Food is moved through the entire digestive system by a process known as peristalsis. And peristalsis simply are wave-like contractions that happen because of the way that the muscles are set up around the GI tract. We have circular muscles surrounded by longitudinal muscles, and one will let go and the other will tighten up, and you can get these kind of wave-like, compressions that go to move food, that moves it through the stomach, and then it's moved into the small intestine, which is moving the chemistry or the chemical product of all of the food through, and then finally into the large intestine where you've got bigger muscles and bigger circulatory muscles that are really moving the very liquidy chyme up the ascending colon and moving the feces down the descending colon as water is being taken out. And then we have a wave-like contraction that occurs in the rectum and certainly in the anal canal. As feces enters the anal canal, the anal sphincter opens, lets the feces come in, it begins to widen, the feces drops down, the internal anal sphincter closes as the external anal sphincter opens. So there's this nice wave effect that goes on that allows everything to move through the system very nicely. So movement in the large intestine, we're going to talk just a little bit about capturing those reflexes that occur naturally in the body. So one of the things we want to think about is that we have mass movements, are strong contractions of the large intestine, and that can happen all at one time. Generally, it can be common after meals. The enteric plexus tends to do it. Sometimes it may be that we eat and then the whole system says, that's it, everything's going. We're going to just have a full clean out. Let's do a big dump. Oftentimes this can also happen after you have a good night's sleep, because now the system has been digesting all night, and guess what? You get up to move and it's like, let's do it. Let's make it happen. Local reflexes that can be instigated by the presence of food in the stomach and the duodenum are the gastric colic reflex and the duodenocolic reflex. So generally the gastrocolic is initiated by the stomach, so the stomach gets stretched enough that it actually tells the large intestine it's time for you to dump. We have incoming. I'm giving you some stuff, so you better make room for the stuff that's coming down the pipe. And the duodenocolic reflex does exactly the same thing, only it's the food leaving the stomach and entering the duodenum that does it. So sometimes it may be a bit of a stretch receptor thing, but oftentimes it's chemistry. Acid begins to enter the duodenum. It needs more alkalinity, so bile drops in, and that chemistry can tell the large intestine, like, do something. And that all goes through the enteric nervous system, which is cool. The defecation reflex is also known as the rectal anal inhibitory reflex, and that is where you have enough pressure or distension of the walls of the rectum by the feces can start the wave action of the rectum that will lead to the wave action and the inhibition of the internal and external anal sphincter to allow the feces to come through and be pushed through. So when we cough or sneeze or increase intra-abdominal pressure for any reason, our pelvic floor should rise up to meet that pressure. But in the case of defecation, we have this reflex that's very, very, very important for those muscles to be able to be inhibited under the case of something actually moving out of the body so that we can actually defecate. Otherwise, we would have the rise of intra-abdominal pressure, and in dyssynergia, the pelvic floor muscles tighten up and lift, and they don't allow the feces to come out. So that's called paradoxical defecation, and that's not what we want to have happen. We want that rare reflex to really work. This next slide shows you a picture of the cecum, which is the bottom of the ascending colon. At the bottom of the cecum is the appendix. The appendix is a harborer of bacteria, which is important for repopulating the gut flora. Ileocecal valve is also present because the ileum attaches to the cecum, and there's a pressure gradient that goes on there, because remember, the small intestine, the ileum, is inside the visceral cavity, and the ascending colon is outside of the visceral cavity. So we have a pressure gradient and a chemical gradient that allows that valve to open and move things through. So when the ileum has the pressure of things building up and ready to come through, there's that pressure gradient and chemical gradient that will open the ileocecal valve kind of on a rhythmic basis to allow the food to drop into the ascending colon, or what's left of the food, the chemical soup, to drop into the ascending colon. The ascending colon is going to churn that and allow more water to come in to build something that we call chyme, and that's what actually is there. So you can also see on this picture of the large intestine the circular muscles and the longitudinal muscles, and peristalsis is very important here because we have to push all of that liquidy chyme all the way up the ascending colon and around the hepatic flexure before it drops into the transverse colon. And then out of the transverse colon, it goes into the descending colon, where water is taken out and the feces are starting to be formed. And we get feces forming and moving down. They move into the sigmoid colon, down into the rectum, and out. Here you see a picture of the descending colon. It's in brown because there's stool in there, because that's what the descending colon is supposed to do. Stool is made, feces are made in the descending colon. That's where water is being taken out all the time. When you have somebody who is not able to go to the bathroom on a regular basis, or they have, for whatever reason, have extinguished their signal to go, maybe they're a school teacher, maybe they are unable to go to the bathroom when they get the signals, Oftentimes what happens is stool will retropulse back up into the sigmoid colon. Well, you're always making feces in the descending colon, so now you're getting a train that's kind of getting backed up the track. And oftentimes you'll be able to feel on people's bellies when they're holding stool in their descending colon area. This is just a picture showing how closely crowded everything is in the pelvis. So you just want to kind of think about that a little bit. There you see the bladder, you see the uterus on top, and right behind it and bunched up there is the sigmoid as it turns into the rectum, and the rectum sits right behind the fundus of the uterus as it goes down to the anal canal. So if we're holding a big load of feces there all the time in constipation, that can affect how we feel around our uterus, and it can certainly affect our bladder, right? So this is one of the reasons that bowels can be a big driver to urinary incontinence and the urgency frequency syndrome, because you don't have a lot of room in that bony pelvis.